So let's begin with the remaining modifier, modifier 57, that is about a decision for surgery. So modifier 57 is a decision for surgery. An evaluation and management service that resulted in the initial decision to perform the surgery may be identified by adding the modifier 57 to the appropriate level of E&M service. So let us take one example. Patient John Smith. The date of service was 28 July 2025 and provider Dr. Thompson checked the patient, and this meeting happened in the outpatient clinic. Now, after checking the patient, the patient had a severe right lower quadrant abdominal pain for the past 12 hours associated with nausea and low-grade fever. Dr. Thompson conducts a comprehensive evaluation. Physical exam reveals rebound tenderness and guarding in the right lower quadrant. Lab shows elevated white blood cell count, and abdominal ultrasound is suggestive of the acute appendicitis. Based on the history, exam, labs, and imaging, Dr. Thompson determined that the patient needs immediate appendectomy. So when I have to do the coding for this, you will code 9920457 because this meeting happened in his office outpatient clinic, and where the doctor decided that the patient require immediate appendectomy, and then you will put the code for the appendectomy. Why do we write the modifier 57? Because there is a global surgical package, and this global surgical package includes the pre-op, inter-op and post-op. So when the doctor decides something and the decision is done, so when I put the modifier 57, the doctor will get payment for that, because otherwise there will be confusion. That service might be included in the pre-op and the doctor will not get paid separately. So in order to get that separate payment, the 57 modifier is important. So let us take one example. Dr. Manning, a thoracic surgeon, was asked to consult Nancy, a 60-year-old female with atherosclerotic heart disease. Nancy, a previous surgical patient of Dr. Manning, was seen in his office on Monday morning for consultative visit due to the mild fatigue and shortness of breath. Dr. Manning performed a comprehensive examination and high complexity medical decision making, determined the need for the coronary artery bypass, which he communicated in the written report to her cardiologist, Dr. Shaw. Nancy was admitted to the hospital Monday evening in preparation for the scheduled surgery. On Tuesday morning, Dr. Manning performed a coronary artery bypass graft procedure using 3 venous grafts and 1 arterial graft, and with the use of cardiopulmonary bypass. He harvested a vein using endoscopic technique, cooled the patient as needed, placed an aortic cross clamp, and completed the anastomosis to the circumflex, left anterior descending and left subclavian artery. Hemostasis was achieved and the chest was closed in layer. How should Dr. Manning report his service for Monday and Tuesday? Now what has happened, Dr. Manning has seen this patient. It is his established patient because he has already operated previous surgical patient. So he has already seen this patient. So it becomes an established patient. Now if you look at the code 99255, it talks about the inpatient consultation. That did not happen. This meeting happened into his office and he knew the patient. So we will definitely require 99215. And we are going to put a modifier 57 because during this visit, the decision for the surgery was taken, and that happened on Monday. And Tuesday he is operated. He has done the 3 venous, 1 arterial graft, and the cardiopulmonary bypass, and for which we will also require the code. So first, after looking at this, A and C goes away. In between B and D, we have to decide the code. So yes, D is the correct answer. We will put the modifier 57 on E&M code, and Tuesday the surgery cabbage happened. It required 3 venous, 1 arterial graft, endoscopic harvesting of the vein also happened. So all that we will cover in these codes. So next is the modifier 58. Stage or related procedure or a service by the same physician or other qualified healthcare professional during the post-operative period. So we already read the definition. So it is all about the stage and related procedure, same physician, and during the post-operative period. These are three important words, and I am giving emphasis on that. Now, what is the appropriate use of modifier 58? It has to be planned either at the time of first procedure or prospectively. Sometimes this procedure may be more extensive than the first procedure, and I mean, for the therapy after the diagnostic surgical procedure we can put modifier 58 as long as it is stage or related. Now, inappropriate use of 58 is we doesn't apply to the procedure with XXX global period. Unrelated procedure during the post-operative period, we cannot write modifier 58 because the definition says it has to be related. And reporting the treatment of the complication from the original surgery that require return to the operating room, there also we can't use the modifier 58 because it is some complication, while the stage and related is one more part of the primary procedure. So do not get confused. If your the concepts are clear, you will never go wrong in putting the right modifier. So let us take one example for you to understand the concept. The patient undergoes the mastectomy due to the breast cancer. During the surgery, the surgeon discusses with the patient that a reconstructive procedure like the tissue expander placement will be done after the initial healing. Now, when I have to code this particular thing, I will code 19303, that is for the mastectomy, and 19357, and I will put the modifier 58 on this because this talks about the immediate tissue expander placement for the planned reconstructive surgery following the mastectomy. So this is how you will use modifier 58. There is one more example. A surgeon perform a procedure to debride a sacral ulcer. During the procedure, the surgeon knows that she must perform a skin graft on the ulcer site at the later date. The skin graft will be built with the modifier 58 because during the original procedure, the physician knew the graft procedure would take place. Now, whenever the ulcer debridement happens, many a time the doctor keeps removing all the dead tissue, and sometimes the wound becomes very deep, and in order to cover that they take the decision of covering it with skin graft. Now in this case, how will I code it? So the debridement code I will put it, and you know the guideline for that, and then I will put the code for the graft, and I'll put modifier 58 on that. So let us take the example. On January 31st, Barbara had a 2 centimeter malignant lesion excised from her left foot. During the post-operative checkup on February 2nd, a residual tumor was noted at the margin of the original excision, and the margins were re-excised. The re-excision include the 3 centimeter excised diameter. How would the same physician code the re-excision? So what has happened? Initially the malignant lesion was excised, and during the post-op checkup they realized some more of the malignant margins were there, so they had to do the re-excision. So what are your codes? So, and which lesion has been excised? Malignant lesion. So go through all the code and tell me the answer. So here there is a very important guideline to report the re-excision procedure performed to widen the margin at a subsequent operative session. See this code as appropriate and append a modifier 58 if the re-excision procedure is performed during the post-operative period of the primary excision procedure. And that's what exactly happened in this case, and that's why we will go with the answer D. Now let us take one more example. James returned 2 weeks after the surgery as planned for a change in his drug delivery system. Today, Dr. Harvey opened a previous incision site. The previously placed reservoir was removed and new programmable subcutaneous pump was connected to the catheter and secured with a suture, tested and programmed. The subcutaneous incision was closed in layer with a sterile dressing place, the patient tolerated the procedure well, how should Dr. Harvey report the service? And we have the separate code. Remember, whenever it is a drug delivery system, we have to pay attention whether they have a separate code for the removal and the replacement, or whenever the replacement happen, the removal code is included in that. So kindly go through all that code and tell me what is the correct answer. So yes, A is the correct answer, and remember, it is a staged procedure which was very clearly planned or changed in the drug delivery system, that has been clearly mentioned. And if you look at all the code 350, it is the implantation and revision, repositioning. But we need to even check the type of the pump, because here it is the programmable pump, and that's what is put up, and that's why this is the correct answer. Modifier 59, very important distinct procedural service. Now we can use a modifier 59 when the documentation support one or more of the following. That is a differentiation or a patient encounter, a different procedure or a surgery, a different site or organ system, a separate incision or excision, a separate lesion, a separate injury or area of the injury. So all those very important, you know, criteria they have given to put the modifier 59. Now they have recently further specified the modifier 59, like if it is a separate encounter, we write XC, encounter EEXE. If it is a separate practitioner, like the two different doctors, so we write XP. If it is a separate structure, we write XS. And if it is XQ, that is a unusual non-overlapping services. So these are the further specification for modifier 59. So when not to use modifier 59, so to report a distinct A&M service on the same date, we use a modifier 25, but never 59. Use modifier 59 only when no better option exists. Always supports is used with clear documentation. Prefer XC, XP, XS or XU when they more accurately describe the distinct nature of the service. So let us take one example. Here present for removal of the three benign subcutaneous cysts. The first lesion excised from her leg is 3 cm, which require a 4 cm incision. The second lesion excised from her abdomen is 5 cm, which require 5.5 cm incision. The third lesion excised from her scalp, that is 0.5 cm, which will require 1 cm incision. The physician performed the intermediate layer closure to the wound on her abdomen. The other wound were repaired by the simple closure. What are the correct code? So what has happened? There are 3 lesions at a 3 different sites, and they are also closed by the different repair method. One is by the intermediate and one is by the the two are by the simple repair. Now if you look at, whenever there is a multiple choice option, you have very less time. So be a smart thinker. The first code is same, the second code is almost same, the third and the fourth code is almost same. So here what they are actually looking, that how good you are with your modifier. And of course you need to check all the code, but the modifier will help you to zero down your code. So yes, last is the correct answer, because first of all, if you have seen that there were 3 wounds, and out of that those 3 wounds were at a different site, and they were also repaired by the different way of repair, that one was intermediate and 2 were simple. So we will always write the repair code, and then we will write the wound code. And remember, if you remember the criteria, that the simple repair is always included in the excision, and we do not code them separately, and these two are the distinct separate procedure. This is the part of that, because this is the repair which has happened for this particular site. So D is the correct answer. Now the next question is, A surgeon performed a radical resection of both the malignant tumor from the soft tissue of the scalp and malignant tumor of the mandible. Bone graft was completed during the same surgical session to the mandible. How would the surgeon code this procedure? So what has happened is there are two malignant tumor at the two different sites, and then the mandible the excision is repaired by the bone graft. So kindly go through the code and let me know the answer. So yes, B is the correct answer because 21015 and 21045, these are the two distinctly different procedure which happened at the two different sites. While this is the part of the bone grafting of the mandible which happened on the mandible. So here I will put modifier 51, but here I will put 59 to say that these two procedures are different, that happen at a different site. And 61501 is not the correct code. Let us take one more example. Polly had the battery changed for her single chamber permanent pulse generator, which was inserted 1 year ago. The procedure was completed in the same session by the same provider. How should the provider service be coded? Now remember, whenever you are dealing with the pulse generator, kindly read the code language because some of the codes includes the removal and insertion. So that is one important consideration here. So yes, D is the correct answer. We are going to write only one code, and if you read the language of the code, it says the removal of the permanent pacemaker pulse generator with the replacement of the pacemaker pulse generator single lead system. And that's what happened exactly. Single chamber and removal plus replacement happened. The patient under general anesthesia had a metaplasty secondary to congenital atresia with a simultaneous tympanostomy. What code correctly captures the services? And we have all this code. Kindly go through all the codes and tell me the answer. So yes, B is the correct answer because if you look at the code 310, it also talks about myetoplasty, but it is for the stenosis due to the injury, and this happened because of the congenital atresia, and we have a separate code for that. So we are going to write the code 69320. And if you look at the code 69433 and 436 is tympanostomy requiring the insertion of the ventilation tube, and 69436 is the tympanostomy requiring the ventilation insertion of the ventilation tube, but it is under general anesthesia and we have the word, so that's more appropriate code. And instead of modifier 59, we are going to put the modifier 51 because this is the multiple procedures which happen at the same site in the same session. So let us look at the next question. Dr. Miss performed the following procedure on a patient: a flexible diagnostic colonoscopy with a collection of the 8 specimen by brushing in the morning. Later the same day, the patient had a diagnostic upper gastrointestinal endoscopy, including the esophagus, stomach, and jejunum with transmural drainage of the pseudocyst. These procedures were not staged or related and occurred during the differentiation. What code captured this procedure? So when you have seen the all the codes, so what happened in this case is there is a colonoscopy that has happened, and in the separate a session they happened a EGD also, that is a esophagogastroduodenoscopy, and so we need to see all the codes and find out the answer. So yes, C is the correct answer. 45378 talks about the colonoscopy, while 43240 it talks about the EJD with transmural drainage of the pseudocyst, include the placement of the transmural drainage catheter stent when performed. And these are the two separate procedure. And since it is not staged, we won't use the modifier 58, and that eliminate the option A, and in between option C and D, you look at the code language, and after seeing all that, C is the correct. Now let us take one more question. A physician performed the laser vaporization of the prostate with a vasectomy. Vasectomy. The patient had some post-operative bleeding that was controlled at the time of procedure. What code captured the service? I always, quickly go through all the the options, and you will see that there are modifiers. So modifier 22 is the more extended service, or when the time required is more, where there is no mention of such, so I can eliminate the option C. And there is only one procedure that has happened, that is a vasectomy, and there is a post-operative bleeding, so I don't think it will require three codes, so I will eliminate that option. Now in between A and B, I'll have to decide the answer. So yes, 52648 is the correct answer, and we have the code language which include the post-operative bleeding, so there is no need to code that separately. Next is modifier 62, it is for the two surgeons. Now again, I have highlighted the important word. When two surgeons work together as a primary surgeons, each performing the distinct part of a single procedure, both should report the same procedure code with a modifier 62. This include any associated add-on code as long as both the surgeon continue to actively participate as a primary surgeon throughout those parts. Each surgeon report the same CPT code with a modifier 62. If additional procedures are performed during the same session, each additional code may also be reported with the modifier 62, provided both the surgeons are primary participants for this procedure. Now, when not to use a modifier 62, if one of the co-surgeon transition to serve as an assistant surgeon for the other procedure during the same surgical session, those services should be reported separately using the appropriate procedure code, like modifier 80 for the assistant surgeon and modifier 82 for the assistant surgeon when a qualified resident surgeon is not available depending on the circumstances. So this two modifier we use it for the assistant surgeon, not the primary surgeon. So let us take example. A 55-year-old patient is scheduled for an anterior lumbar interbody fusion at L4 L5 level with anterior instrumentation. Dr. Lee, a general vascular surgeon, performed the anterior retroperitoneal exposure of the lumbar spine. Dr. Patel, an orthopedic spine surgeon, performed the actual interbody fusion and placed the anterior instrumentation. Dr. Lee remained scrubbed in and assist with the interbody device placement and the closure. So in this case, what they will do is both the doctor will write both the procedure code, like the arthrodesis interbody technique and the instrumentation, and they'll put the modifier 62. Both the surgeon participated in the distinct critical portion of the same primary procedure and were core surgeon, not assistant. So modifier 62 is correctly applied to each code. So let us take example. Dr. Martin performed an excision of the vascular lesion located in the middle cranial fossa. The procedure was completed in an intradural fashion and included the dural repair and graft placement. During the same operative session, his partner Dr. Sutter performed an infratemporal approach with a decompression of the auditory canal. How should Dr. Martin report his service? So first of all, whenever you are coding for the two doctor, pay attention whether they have asked for the whole service or whether they have asked for the particular doctor's work. And here they have asked the work of Dr. Martin, and what Dr. Martin did is the medial cranial fossa excision of the vascular lesion, and the procedure was completed. And then there was a Dr. Sutter also who did a decompression of the auditory canal. So pay attention to that. So yes, we will use the code 61606. There is no need of modifier 62 because Dr. Sutter performed a separate procedure. It is not a co-surgery, and there is a sentence that Dr. Martin completed his procedure. So we will use the modifier C. We will use the answer C. Modifier 63, procedure performed on the infant less than 4 kg. Every word is very important. So let us understand modifier 63. It should be appended only once per procedure code. This modifier may not be append to ENM code, anesthesia code, or any code outside the range, range specified. This modifier, it basically says that there is an increased physician work because of the smaller anatomy, delicate tissue handling, greater risk of complication, and higher need for monitoring and the precision. Modifier 63 does not require prior authorization in most of the cases, but documentation should clearly support the infant's weight and added complexity. However, not all the CPT codes are eligible for modifier 63. Some codes are specifically designated as modifier 63 exempt, meaning you should not append modifier 63 to them, and we have a special appendix for that. So here is the appendix F, which talks about the summary of the CPT code exempt from modifier 63. And if you take the example of that, and here also you will see that there is a particular note that do not report modifier 63 here. So I have taken some of the examples from here and I checked them into the particular chapter, and everywhere you will see the modifier 63 should not be applied, and it's a very clear cut parenthetical note, so it is important to read the parenthetical note. Now let us take one example. A newborn circumcision is performed, infant weighing 3 kg. How would you code this procedure? And we have the code 54150, 5416063, 54160, and 54161. Age of the patient is 3 kg and he is a newborn. So tell me the answer. And yes, the code is 54160, and there is no need to put the modifier because first of all, this is, they have clearly mentioned 28 days age or less. So the factor of 4 kg is already included in the code. And there is a parenthetical note which says that do not put a modifier 63. A 6 months old patient require a bilateral subdural tap through a suture is performed. How would this initial procedure be reported? And we have the various code. So it is a bilateral subdural tap. Now, if we look at the code, find out whether it is a subsequent tap or the first tap, and there is no mention of the word subsequent. So I can eliminate the option 61001, and this is the ventricular puncture that did not happen. So in between A and C, we need to zero down the answer. So yes, 61000 is the answer. We have already eliminated the answer B, and B, there is no need to put a modifier 50 because though the procedure is bilateral, we have already seen that language in the code. Modifier 66, surgical team. So surgical team is under some circumstances highly complex procedure requiring the concomitant service of several physicians or other qualified healthcare professional, often of a different specialities, high skill, specially trained personnel, or various types of complex equipment are required, and that cannot be done by one person, but it is by the team. For example, the heart transplant. Modifier 73, discontinued outpatient hospital or ambulatory surgery center procedure prior to the administration of anesthesia. I have written the word in a bold letter for you to absorb. So this particular modifier is whenever a surgical or the diagnostic procedure that was discontinued prior to the administration of anesthesia due to the extenuating circumstances or those that threaten the patient well-being, and that happened in the outpatient or in the ambulatory surgery center. So these words are very, very important. And So the patient must have been prepared for the procedure, including any procedural pre-medication, and transported to the procedure room, but the procedure was terminated before the anesthesia was administered. These are very, very important words. And what are the key points? Use only when no anesthesia has been administered. The facility append modifier 73 to the CPT code for intended procedure, not applicable for the inpatient procedure, very important, or if the anesthesia was already given, because for that we have a modifier 74. So please go through the theory again. Now let us take example. Patient Rita scheduled for diagnostic EGD in ambulatory center. As the patient begins preparation, she develops significant hypotension. The physician cancelled the procedure. Anesthesia has not been administered. The patient has not been moved into the procedure room. How should you report this procedure? So what has happened? The Rita was to undergo diagnostic EGD. The patient preparation was begin, but she developed a hypotension, and that's why the procedure was terminated prior to administration of anesthesia. Now go through all these options and tell me the answer. So yes, 43235 is a diagnostic EGD code, and we are going to put a modifier 73. 53 is for the inpatient, 74 is after the administration of anesthesia, and 52 is for the reduced service. So 73 is the most appropriate. Now let us look at the modifier 74. It is a discontinued outpatient hospital ambulatory surgery center procedure, but after the administration of anesthesia. That is a very, very important word. Now this modifier 74 is discontinued after the administration of the anesthesia or the procedure was initiated, but due to the extenuating circumstances or the condition that threaten the patient's well-being, the procedure is stopped, and again it is for the outpatient and the ASC. Now, what is the appropriate use? The procedure is performed in an outpatient hospital. The patient was prepared for the procedure. The anesthesia was administered, and the procedure was started but could not be completed due to the extenuating circumstances. And what is the incorrect use? Not applicable if the procedure was electively cancelled or postponed, and do not use if the procedure was terminated before the administration, because for that we have seen the modifier 73. And documentation should clearly support the circumstances leading to the discontinuation after the anesthesia. So these are the important points. So let us take example. Here the 65-year-old Mr. John was taken to the OR for the laparoscopic cholecystectomy. After the portal incision was made, it was noticed by an anesthesiologist that the patient was in a ventricular fibrillation on the cardiac monitor. Defibrillation ensued into which resulted into abatement of the arrhythmias. The procedure was cancelled pending a cardiac consult. The CPT reported for the cancellation of the procedure would be, and these are the options. Kindly go through the option and tell me the answer. So yes, B is the correct answer, because what has happened here is the procedure has started, and then because after the portal incision was made, the procedure has started, anesthesia was given, and then the anesthetist realized that the patient went into the ventricular fibrillation. So 74 is the most right modifier, and so we'll go with the option B. Modifier 76, it is the repeat procedure or a service by the same physician or the other qualified healthcare professional. So modifier 76, we will use it when the exact same procedure is performed more than once on the same date of service due to the medical necessity by the same doctor. So I'm emphasizing the word same provider, same procedure, same patient, same day. and it has to be medically necessary. And we can use this modifier in the hospital, outpatient or office setting, and it can apply to diagnostic as well as the therapeutic process. So modifier 77 is a repeat procedure or a service by another physician or other qualified healthcare professional. So the only word here is another doctor, but otherwise it is also the repeat procedure and or the service. So let us take one example to understand the nitty-gritty of 76 and 77. On January 1st, 2024, Dr. Miller ordered to view chest X-ray at 10 a.m. Later, due to the medical necessity, he ordered a repeat to view chest X-ray at 11:30 a.m. On the same day, subsequently at 2 p.m., a different physician, Dr. John, from a different specialty, also ordered to view chest X-ray on the same patient. So how will you code it? 10 a.m. 71046 radiological examination, chest 2 views, initial study by Dr. Miller. Then 11:30 a.m. 71046, that is a repeat procedure by the same provider, same day. We will use the modifier 76. It is used to indicate the repeat procedure by the same physician. At 2 p.m., the two chest X-ray which are taken, we will code 7104677 because it was a repeat procedure, but here the provider was different, and so we will use the modifier 77, and this will be the complete work for this case. So let us take one question. Patient has a diagnostic EKG in the morning due to the chest pain. Later that day, the same physician repeats the EKG due to the new symptom developed. How will you code the service for the day? And you have three options. Kindly go through this option and tell me the answer. So yes, C is the correct answer because the same physician repeated the same procedure on the same day. So 76 is the most appropriate modifier here. And this is my last slide for this particular part. And then we have one more part where we'll finish all the CPT level 1 modifiers.